Fundamentals of clinical dermatology. Morphology and special clinical considerations. Introduction. Skin diseases exhibit characteristic morphology and distribution. Morphologic characteristics and reaction patterns of the skin aid in suggesting disease pathophysiology and focusing differential diagnoses. Patient history is crucial for complex diagnoses. Proficiency in dermatologic terminology is essential for effective clinical documentation, research, and communication. A comprehensive mucocutaneous examination, including hair and nails, should always be performed. The art and science of dermatologic diagnosis. Diagnosis and treatment of skin diseases require recognizing primary lesions and reaction patterns. These visual clues must be put into context with the patient's history and overall health. Accurate identification of morphology is an essential step in generating a differential diagnosis. Subtle details like hue of erythema, shape, distribution, or findings on nails or mucous membranes are key to correct diagnosis. Experience and associate clinical findings with histopathologic features for a deeper understanding. Dermatology is a visual specialty, but history is crucial in complex cases. Example: rash with fever, generalized pruritus. Taking a detailed patient narrative can provide therapeutic value, relevant information for treatment, and opportunities for education or reassurance. Primary goal is to establish a diagnosis. Secondary goal is to evaluate patient as a candidate for therapy. For established diagnoses, goals include reevaluating, monitoring progress or complications, and modifying treatment. Key components of history taking. Duration, timing such as constant, intermittent, worst at night or winter. Evaluate the changes of the lesions over time. Location and presence of any symptoms such as pruritus, pain, bleeding, non-healing, associated with fever or systemic signs. Comprehensive review of systems for cutaneous signs of systemic disease. The severity of the lesion over time with 1 to 10 scale. Ameliorating and exacerbating factors such as sun, heat, cold, trauma, exposures, menses, and pregnancy. Preceding illness, new medications such as topical products and exposures. Therapies tried and response. Prior similar problems, diagnoses, and study results. Focused or comprehensive, depending on diagnosis. Example: joint symptoms in psoriasis. Medical history. Chronic illnesses, diabetes, renal or hepatic disease, HIV, PCOS, lupus, thyroid disease, asthma, and allergies. History of surgical procedures including organ transplantation, immunosuppression, pregnancies, psychiatric disease, history of blistering sunburns, arsenic or ionizing radiation exposure. Medication history. Detailed, including prescriptions, non-prescription, vitamins, supplements, herbal remedies, focusing on recent starts. Allergies to certain medications, foods, environmental antigens, contactants. Social history. Occupation, hobbies, alcohol, tobacco, and any illicit drug use, sexual history, diet, bathing habits, pets, living conditions, travel history, cultural or religious practices. Family history. Skin disease, atopy, atopic dermatitis, asthma, hay fever, and skin cancer. Approach to the patient. Physical examination. Scope of complete cutaneous examination. Inspection of entire skin surface including scalp, eyelids, ears, genitals, buttocks, perineum, and interdigital spaces. Hair, nails, and mucous membranes, eyes, nose, mouth, genitals, and anus should be examined. These will help in identification of harmful lesions, skin cancers, reassurance for benign findings, locating additional diagnostic clues, patient education, and conveying physician concern. Ideal conditions for complete skin examination include excellent lighting, preferably bright natural light. Patient fully undressed and gowned, with additional draping if desired. Removal of underwear, socks, shoes, makeup, and eyeglasses. Comfortable examining table such as reclinable head, extendable footrest, and stirrups. Comfortable room temperature. Sink for hand washing and disinfecting foam. Chaperone is required, especially opposite gender, among patient and physician. Recommended tools in physical examination are: magnifying tools such as loupe, magnifying glass, and dermatoscope can be used. Bright focused light. Glass slides, which can be used for diascopy, viral DFA, fungal scrapings, zinc smears, or scabies prep. Alcohol pads, gauze pads, or tissues with water. Gloves for suspected contagious conditions, contact with body fluids, mucous membranes, or genital areas, and procedures. Ruler for measuring lesions. Scalpel blades, number 15 for scraping, and scalpel blades number 11 for incising. Diagnostic solutions, KOH, oil, zinc smear, and culture media. Camera for photographic documentation. Wood lamp, 365 nanometers, for highlighting subtle pigmentary changes. Technique of dermatologic physical examination. Consistency is essential to avoid overlooking areas. Observe patient at a distance for general impressions for asymmetry, cachexia, and jaundice. Systematic head-to-toe examination, uncovering one area at a time to preserve modesty. Move patient and illumination for best view. Side lighting can reveal depth and lesion border details. Palpate lesions, whether it is soft, firm, tender, or fluid-filled. A head magnifier frees hands for palpation. Dermatoscope is required especially for pigmented lesions. Careful examination of mucosal sites with additional illumination. Reassure patients by reporting benign lesions. Document skin findings, type and location, descriptive on body map. Photography and triangulation are crucial for suspicious lesions undergoing biopsy. This show brief physical examination. Look for the general conditions of the patient: well of ill, obese or cachexic, pallor or jaundice, warm or cook, and characteristics of skin surface, xerosis or seborrhea hydrosis condition, and degree of photoaging. Careful examine the morphology of the lesions, which would discuss later. General physical examination include vital signs, abdominal examination, pulses, and lymph node. Introduction to morphology. Work by Joseph Jacob von Planck and Robert Willen established basic morphologic terminology. To read the skin, one must recognize the basic lesions. Elemental building blocks of morphology are: primary lesion and secondary epidermal change. Macroscopic characteristics help understand microscopic pathologic changes, clinical pathologic correlation. Flat-topped planar papules or plaques affect epidermis and superficial dermis. Dome-shaped or nodular lesions, deeper infiltration into dermis or subcutis. Scaling or crusting, epidermis affected. Smooth, intact surface on palpable lesion, purely dermal or subcutaneous process. Combination of primary morphology and secondary change defines a reaction pattern, which narrows the differential diagnosis. Other characteristics like shape, color, configuration, arrangement relative to each other, and distribution on the body further refine the differential diagnosis. Awareness of variations and ambiguities in morphologic term definitions is important. Primary morphology describes in 3 lesional characteristics: size, topography, and character of contents. Primary morphology is the noun described by adjectives like color, shape, size, and texture. Erosions and ulcerations can be primary or secondary. Primary lesions are macule, patch, papule, plaque, nodule, vesicle, bulla, pustule, erosion, and ulceration. Flat, non-palpable primary lesions. Macule. Macule is a flat, even with surrounding skin or mucous membranes, which has color change only and less than 1 centimeter. Patch. Patch is a flat with color different from surrounding skin or mucous membranes and 1 centimeter or larger. Raised, palpable primary lesions. Papule. It is an elevated or depressed lesion less than 1 centimeter, may be solid or cystic. Topography can be sessile, pedunculated, dome-shaped, flat-topped, filiform, mammillated, acuminate, conical, or umbilicated. Plaque. It is a solid, plateau-like elevation or depression with a diameter of 1 centimeter or larger. Nodule. It is a palpable lesion greater than 1 centimeter with a domed, spherical, or ovoid shape, solid or cystic. It has 5 main types based on primary anatomic involvement: epidermal, epidermal-dermal, dermal, dermal-subdermal, subcutaneous. Texture may be firm, soft, boggy, or fluctuant, and surface may be smooth, keratotic, ulcerated, and fungating are important. Tumor, sometimes used to describe a more irregularly shaped mass which may be benign or malignant. Fluid-filled primary lesions. Vesicle. It is a fluid-filled papule smaller than 1 centimeter. Bulla, blister. It is a fluid-filled lesion 1 centimeter or larger. Vesicle and bulla's wall is thin and translucent, allowing visualization of contents which may be clear, serous, or hemorrhagic. Arising from cleavage in epidermis, intraepidermal or dermal-epidermal interface, subepidermal. Tenseness or flaccidity may suggest depth of split, but histopathologic examination is needed for reliable differentiation. Pustule. It is a circumscribed, raised papule in epidermis or infundibulum containing visible pus. Pus include leukocytes with or without cellular debris, may contain organisms or be sterile. Color is often white, yellow, or greenish-yellow. Can be varied in size and coalesce to form lakes of pus. May associated with hair follicles or may appear conical with a hair in the center. Secondary change, epidermal or surface change. Scale is the macroscopic finding indicating epidermal change, usually stratum corneum. Descriptive characteristics are soft, rough, gritty, bran-like, and micaceous. This table shows type of scale and its description. Craquelle or xerotic is dried and cracked skin appearance. Cutaneous horn is conical projection of compact stratum corneum. Exfoliative / or desquamative is scales split off in finer scales or sheets. Follicular scale is keratotic plugs, spines, or filaments. Gritty is densely adherent, sandpaper texture. Ichthyosiform scale is regular, polygonal plates in parallel rows or diamond patterns, fish-like. Keratotic or hyperkeratotic is thick, compact, adherent layers of stratum corneum. Lamellar is thin, large plates or shields attached in middle, loose around edges. Pityriaciform is small and branny. Psoriasiform, micaceous and ostraceous, is silvery, brittle, thin plates in loose sheets, mica-like. Large scales may accumulate in heaps, oyster shell-like. Seborrheic is thick, waxy or greasy yellow to brown flakes. Shellac-like scale is shiny with a sheet-like desquamating edge, like peeling paint. Wickham striae is lacy white pattern overlying violaceous flat-topped papules. Secondary changes include crust, which is dried fluid on skin surface which may be serum, blood, pus, or combination. Round or oval crusts indicate former vesicle, bulla, or pustule. Linear or angulated crusts indicate excoriations. Eschar is dry, adherent, dark red, purple, brown, or black, signals skin necrosis. Fibrin is soft, yellow crust on surface of some ulcers. Lichenification is thickening and accentuation of skin lines from repeated rubbing or scratching, seen in chronic or neurogenic or eczematous processes. Other secondary change include atrophy. It has epidermal and dermal atrophy. Epidermal atrophy is shiny quality with cigarette paper wrinkling. Dermal atrophy is depressed lesion. Fissure is linear loss of skin or mucosa continuity from excessive tension or decreased elasticity, common on palms or soles due to thick stratum corneum.